Want to say again that I think this is a really important segment, and I know we're going to go to a break. We're going to actually do some open mic stuff after I'm done presenting the short presentation that I have, and Dr. Smith is going to come in, but we have a break, and then one of the lead community-based organizations in the country for sickle cell disease, President Mary Brown, is going to speak, and I really do hope that you're all able to stick around. She's done some amazing work over the last 40 years, and she is nationally recognized as an expert. So I just wanted to put that out there because I think I know everybody gets tired. It's Friday afternoon, and y'all been hanging really tight with us, which we're really excited about, but I just wanted to bring that to your attention. So, I said this last year, and I'm going to say this again. I think there's probably people sitting on this panel who probably even know more about this than I do. But I did feel that there are some things that we should bring to your attention, more specific as a result of a report that Dr. Smith had alluded to, I think either in his first or second day of his talks. And it's really involving the national report from the NATION report, where it really focuses on the sickle cell community-based organizations and the role that they play. And if you take a look at one of the comments they made, they said that the community-based organizations are valued, and they would consider them to be like the gatekeepers to the sickle cell disease community. They definitely have their finger on the pulse of the community, which is kind of going back to what Joan was just talking about. And this role has become very important and has evolved over time. For those of you who probably have been in organizations a lot longer than I've been a part of working with them, you know that there's been a lot of more positive changes and more involvement with parents and families into these groups. And now it's actually being recognized on a national level. So there's a long history of sickle cell disease CBOs or patient organizations. And, the biggest thing that we've really focused on a lot here today in my talks is the advocacy for need, or the need for advocacy, I'm sorry. We really do need to have voices out there for those who cannot speak for themselves. And these groups are, like I said, usually dedicated to people who have a direct involvement in the sickle cell community. So of course, they have the challenges, they've experienced the challenges, they're families of people who have had challenges, and they know what voices need to be out there to continue to advocate for the needs of these patients. They also are important in generating awareness. They are there to educate the community. They're really a voice between probably people who care for sickle cell patients and the community who, in our case with dealing with sickle cell disease, still kind of think that it's either been cured in 1970 or that somehow it no longer impacts the community. So they do a lot of work in bringing awareness. There's also various levels of these organizations. There's the national level, the state level, and of course the level that we deal with more on a day-to-day basis, which is the local levels. And of course, each of these groups are structured differently. Some have much more direct relationships, integration into the sickle cell medical homes around the country, where others might have to sit back a little bit further and not have that direct relationship. I know that, for example, in our organization, we have just really begun structuring a more, and I'm going to talk about this in a few minutes, but a more direct triad, which is now called the CRIAD, relationship with our community-based organizations, where they're now coming into being more part of the groups that we're working with patient care. They also are there to improve the lives of individuals, and I think that that's really important. Not that those of us who care for patients are not there to improve their lives, but their relationship with them is different than ours. And of course, most of these organizations are hampered by financial resources and infrastructure challenges. I think Joan was alluding to this in her talk. Most people who are working in these organizations are not paid. They're volunteered. They have day jobs. They have families to take care of. They're constantly battling with their state or local governments to help them fund these programs. And it's really challenging to try to have them in those day-to-day operations if, of course, they have other responsibilities that they need to take care of. And, of course, they need to have that unified voice to really affect the large-scale changes that need to occur with sickle cell disease. So We wanted to go back to the NASEM report where the models that they talked about involving rare diseases was really important to these organizations being formed and being able to be structured at a level that could really promote change. And there was 3 key components that they actually focused on, which was to restructure the organizations for sickle cell disease, CBOs, and kind of make them feel more integrated into the communities that they're serving. Define what their capabilities are and be able to embed their role within the care delivery of the healthcare system. I really feel that this is instrumental, and as we're moving forward through the next 5 to 10 years, we're going to see this continuing to evolve. And I know Dr. Smith will maybe bring this up when he comes out here, but there has been some interest actually on the federal level in making sure that some of this, these reporting outliners are being followed, and Dr. Smith has been a key to that, and I think he did mention that on one of his talks, and I think that's really important. And there also needs to be diversity in the funding sources. It kind of goes back to what we were speaking about, even like in building our teams. We can't constantly rely on the federal government or grants or other resources that maybe, depending on what political party might be involved, they may cut those resources, they may increase those resources. So it's really kind of important to work both in the federal sector as well as the private sector to be able to get funding for these organizations. Now, there's national efforts that encompass the interest of all the CBOs, and they sometimes have their own challenges. These also are under-resourced organizations, but there's some that have been around for a long time, and there's one that is actually newer to the group. Many of you are very familiar with the Sickle Cell Disease Association of America, and I'm not sure if anybody from the SCDAA is in on the conference, and if you are, welcome. But there's also a group that was formed in 2014 called the Sickle Cell Community Consortium, and this group was founded to be able to harness and amplify the power of the patient voice. It's a group of basically people who are called like the General Assembly of CBOs, where they have CBOs, patients, caregivers, advocates, medical directors, and researchers sitting on these panels to help make overall decisions on things that are really going to vastly improve the work of the community-based organizations. So going back to the NASEM report, there's 3 key components that we want to talk about and how we can improve the relationship with the community-based organizations and the work that they're trying to do. First, there needs to be public education and awareness and information that we are able to disseminate regarding the health condition of sickle cell disease. Public awareness and understanding of the disease are limited, which places the burden on individuals to educate their parties, whether it's the healthcare system, the schools, their places of employment, clinics, whoever may need to have this information. I know the professorship that Dr. Smith is named after, the Florence Neal Cooper Smith Professorship, for the last 30 or 40 years, and she's still alive, Miss Cooper Smith, and she's wonderful, and she's going to be celebrated again here in June for all the great work that she's done. But her focus has always been on the Black churches, and she's been going out there for decades really trying to educate them about the work and the needs of patients with sickle cell disease, and that it's still out there. We also need to provide enabling services to the sickle cell disease community, and again, this is where the CBOs and patient advocacy groups are best positioned to provide these enabling services, including the social and peer support, which goes back to that peer community health worker, hospital visitations. I know that there was a time when we were really trying to do like an adult to a pediatric patient peer group. So like parents, when their children are hospitalized, they still have to go to, work. They still have jobs to tend to, other baby children in their home. And we were really trying to see if we could get some adult patients who might be willing to go into the pediatric units and sit with kids and read to them and do different projects. And I think these are really services that we need to continue to try to enhance on, as well as providing recreational and social activities to address the isolation and the need for communities that individuals need to feel like they're inclusive of with them having this disease. And we also need to talk about the bridge between the sickle cell disease population and the scientific and clinical communities. And I do think that this is probably an area that some places are probably doing a really good job on, but probably the majority of research does not really include the CBOs being part of helping the recruitment for sickle cell disease patients into these particular trials. The only way for us to be able to continue to make improvements on sickle cell disease care is to continue to have research being done. And I understand there's a lot of stigma behind that. I understand the past history of all that, but really the community-based organizations might be the key to help us being able to recruit individuals into these research projects so that we continue to make changes in medications and hopefully someday find a treatment for sickle cell disease. So there's services that are offered for community-based organizations, include several federally funded programs, and this is the Sickle Cell Disease Treatment Act. There is the NIH, which is the National Institute of Health, which we have talked about several times throughout this conference, and how we kind of got started in our Patient Navigator program came as a result of funding from them. There's also the CDC, which is, of course, the National Hemoglobinopathy Resource Lab for us to be able to continue to work on diseases like sickle cell and be able to provide counseling and support to communities as well as to researchers in the community. And then there's HRSA. And HRSA really has taken a forefront in being interested in community health workers and doing what they can to try to improve the lives of people with sickle cell disease by working more into the networking of the communities. So services offered by the community-based organizations really remain invisible in many communities. But in states like Virginia, we actually do have, and I know several of you are on here, we do have some really great organizations where we have been trying to reach people and do the engagement and support that is not typically being done or measured in the scientific publications. So I think that one of the goals we should really look at maybe over the next year before we come together for another conference is to really think about how can we empower the community-based organizations to really be able to step up to the plate and feel empowered and feel supported to be able to provide the support that is needed to really help with research and be able to be included in the scientific community. We also need to make sure that there is a definition of the scope and the sphere of what they are doing in the community, and that we don't want to duplicate services, but we want to make sure that the services that are being provided by the CBOs have their own component, because many times in the academic setting, we have different ideas and different therapeutic outliers that we need to make sure that we're providing. I think that it's really important to recognize the boundaries that each of us have. And, there's many things that could be done on a non-professional level that really helps patients and family members that are very much in need of support. And there's also the individuals who have the professional training on the academic side that can come in there and provide the therapeutic support and have the ability to go out there and really provide the assessments and the needs for patients, whether it's through mental health, whether it's through substance abuse, whether it's through transition, whatever the dynamics are. And so sometimes those two things could come together. And I know that the networking of that is very important, but we also need to make sure that we know where our boundary lines need to be drawn and that we're not trying to do something that maybe qualifications for that particular person might not be where they need to be. And I think sometimes that is very challenging for both sides of the coin. So, why do we think CBOs are really important partners for the healthcare system? Well, I don't think we did for many years. I think that they kind of were out there on an island of their own, and they were sometimes maybe working properly with the physicians that were taking care of our patients. But many times I think that they were out there trying to do what they can for the patients that they were serving with no resources, probably volunteering their time, and really trying to make a difference, but really did not have all of the backing of those of us here who might be able to get them to the next level. Over the last 5 or 10 years, I think that's changing, and I think it's going to continue to change. I know some states that have people sitting here on this conference have definitely been more progressive than others, and I applaud them for all the hard work that they have done to really put their voices out there and be able to establish themselves very well in the community. But we really need to have them to be part of our healthcare system. COVID has definitely impacted that. We were really working diligently to try to get our local CBO to start coming into our adult clinic, being able to kind of meet adult patients, kind of get them set up with their support group, and then COVID hit. And now we're at a place where we might be able to have them start coming back in. I know that, I think they're coming into the pediatric clinic again. We haven't really reestablished that in the adult clinic, but it is something that is really important for them to be that person that maybe when that patient is coming out of the room, they see them and they feel that there's a connection to them, and they can, get their email address and start sending them flyers for events. And even though most things are still virtual, they can still go ahead and get them to feel like, hey, there's people out there that can listen to you. So I do think that there's a lot of things that the CBOs are able to do, and I'm thinking back to COVID again. We really work with our CBO. We provided them some financial resources. They were able to get backpacks out to patients, thermometers, food, different things as far as supporting them for housing if they needed it. So there's a lot of great things that they could do that maybe we don't have the time or the ability to do. And they also can work hand in hand with our case management team, which in this case is our patient navigators. So I just wanted to bring this to your attention real quickly before we have Dr. Smith come in here and join us. So I had mentioned that the PCORI grant that Dr. Smith and some of our team has been working on for the last 4 years now, which is about to wind up after another year, we originally started out calling ourselves a triad. And then we realized as we were kind of moving through this that we also became a quadrad, which I really kind of botched that sometimes, so I apologize for that. It's a new concept for me. But if you look at this, we originally had the pediatric department here, the adult department here, the patient here, and the CBO. Well, really, the pediatric and adult program are really one program. And as we're really working towards this lifespan program, we do want to make sure that we're inclusive from, somebody used the word womb to tomb. And I think that's kind of where we're looking at this now. And then we have the CBO down here that we're really starting to try to, work on that relationship, make it better, make them feel like they're included in our discussions and we in theirs. And then of course there's the patient. Some patients may not want to be involved in a community-based organization, but they still want their voices to be heard. And they may have other things that if we do connect them with that CBO, they're able to get the help that they need. So we now have this quadrad approach, and we're really kind of excited on moving forward with this and seeing how this continues to play out with us as we finish up our grant and then continue on to our next step in our relationship building. So I see that we have no questions, and we did want to take some time to bring Dr. Smith back in here so that he can probably get you to open up your mics a little bit. I know maybe there's been some chattering going on in the comment section, but we really would love to have that chattering, more where everybody can hear what you're saying. So I'm going to turn the floor back over to him, and we'll see you as we're wrapping up our day.